Hello and welcome to Talking Meds, a podcast from PrescQIPP, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, Medicine's Clinical Advisor here at PrescQIPP. Hello and welcome to the latest episode of Talking Meds. Today we're going to be talking about penicillin allergy delabelling, colloquially known as PADL, therefore not to be confused with the ever-growing popular racket sport. For that, I'm joined by Philip Howard, who is by any measure a leading expert in the area of antimicrobial stewardship. Phil is the AMR Regional Antimicrobial Stewardship Lead for NHS England North-East Yorkshire and is past president of the British Society of Antimicrobial Chemotherapy. He's a member of the Department of Health Advisory Group on AMR and healthcare-acquired infections and is still closely involved with helping NICE produce guidance on infectious disease. He was formerly part of the Common Infections Guideline group that I led while I was at NICE. Happy times, eh, Phil? He's published extensively on many issues around antimicrobial stewardship and antibiotic shortages, and has been involved in AMS education and training across the world, frankly. He's won a load of awards over the years, but I know he was incredibly proud to receive an OBE for his services to healthcare. He also lives in a wonderful part of England, in the northeast of England on the coast, about 5 miles down the coast from where I grew up. And unfortunately, Phil has made the incredibly poor decision of supporting both Leeds at football and Scotland at rugby, rather than following the Red Rose of England. So, welcome, Phil. How you doing?
What a wonderful introduction. Yes, great to come and talk to you all.
Brilliant. So Phil, what brought you to the kind of career position you're in now then? What's your career journey?
A long one. So I'm currently 61. So I've been doing pharmacy for a really long time. I'd worked as a clinical pharmacist and then a clinical pharmacy manager at the Leeds hospitals ever since the late 1980s. But I'd always had an interest in antibiotics. In 2008, the Leeds teaching hospitals had really high rates of MRSA and C. diff infections, and the Department of Health came in and told us to get our house in order. So I did a 6-month secondment focusing on trying to reduce these rates and really getting our antimicrobial stewardship within the organisation in a place where it should be. And as part of that, we put a bid together for our first consultant pharmacist post. And actually really, I realized that I enjoyed doing the consultant pharmacist thing more than being clinical pharmacy manager. So I applied for it. And I think I still am the only consultant pharmacist who's ever taken demotion in the country. And I was lucky enough to work with a really visionary chief pharmacist, Liz Kay, who's retired now. But she realized that allowing her pharmacists to be able to do things academically or on secondments in various leadership roles in different specialties actually would be really beneficial for the department coming on. And then, as you've mentioned, I've done various leadership roles in clinical pharmacy, chairman of UK CPA, first pharmacy president of the British Society of Antimicrobial Chemotherapy. But specific to this, I suppose, is I did a secondment from 2015 to 2019 working for the then NHS Improvement on antimicrobial resistance for 1 or 2 days a week. And during that time, the chief pharmacist for England, Keith Ridge, had various conversations about getting funding in place for a proper network for antimicrobial stewardship in England. And then after the COVID pandemic, the money actually came through. And so it was a team was set up with the national lead for antimicrobial stewardship in NHS England, Kieran Hand, and then a network of 7 regional antimicrobial stewardship leads with some project support officer place. And I took up one of these roles up in the North-East Yorkshire region in 2022. Now, one of the great things that Kieran Hand set up in all of this is I do one approach. So each of us takes a lead on national portfolio roles. And one of mine is antimicrobial medicine safety, which covers penicillin allergy on there. So that's how I came into the role. I still have a visiting professor role at University of Leeds, which I've had for a number of years. And a lot of my NHR-funded research has been around infection diagnostics, but specifically around penicillin allergy delabeling. And if you cast your minds back to 2013, Dr. Jonathan Sandoz, a microbiologist in Leeds, and I were batting around ideas, and we came up with the idea of a penicillin allergy delabeling project. But it took us many, many years before we actually got an NIHR program grant. And that's really how this whole thing came to fruition.
Brilliant. Thanks, Phil. So, I mean, we've been talking about antimicrobial stewardship certainly ever since I qualified in 1989 and probably before that. And probably even, just as antibiotics were discovered, there were issues with resistance to them, wasn't there? I mean, I certainly remember the getting ahead of the curve report when Liam Donaldson was the chief medical officer. I think that was in about 2002. And then Dame Sally Davis took on the mantle, didn't she? And very, very passionate about antimicrobial stewardship. So I think there is a danger, isn't there, that we've become a little bit blasé about antimicrobial stewardship. So why is it as important as it was, or maybe even more so than ever?
Yeah, I think you're right there, Jonathan. I think one of the things we've forgotten really since we started having access to them in the 40s is we almost take them for granted now. But what we forget is that antimicrobials really were the birth of modern medicine. It allowed us to keep premature babies and the very old and infections alive, allowed us to do complex surgery, transplantations, give cancer chemotherapy. And if we lose effective antibiotics, then modern medicine is really going to be threatened. And one of the things that I think sometimes people forget about is that antimicrobial resistance is actually driven by use, whether it's appropriate or inappropriate use on there. And it's all about evolution. And where in humans, we have a generation which is 20 years, and E. coli bacteria's generation is only 20 minutes. So you have the opportunity for evolution quite quickly. And we know that all bacteria will become resistant to an antibiotic with enough exposure. Sadly, the antibiotic pipeline is very weak. It costs about $5 billion to bring a new antibiotic to market. And then when they are marketed, we don't use them. So pharma have generally left antimicrobials. And then despite all the new models of funding for early research and then trying to de-link antibiotic use from payment. So in the UK, we're leading probably the way in the world at the moment by actually having subscription models for new antibiotics. So a bit like your gym membership. We're really good in January, aren't we, of going to the gym, pay our money, but come June, July, or when you've had your holidays, we don't tend to go to the gym as often, but we're still paying for our gym membership. And so that's a way of getting the pharma instant payment for actually the large amount of money. Every year, though, the UK Health Security Agency bring a report out on antibiotic usage and resistance. And one of the things that's shown this year is that the incidence of bloodstream infection rates has actually increased by about 4% since before COVID, so 2019. And just under a quarter of these were actually resistant to our normal first-line antibiotics. So that's a bit of a challenge for us. And this has actually increased by 13% since 2019. What does this mean? It means that these patients are more likely to die within 30 days. And we had almost 2,500 patients die from gram-negative bloodstream infections in England last year. And even more worrying is it's a real health inequality in that the most deprived populations are almost 50% more likely to have resistant infection, and thus they will have a higher mortality rate, and this is growing each year. So to put it in context then, we've got few new antibiotics, use drives resistance, so stewardship is more important than ever. And just to remind our listeners what antimicrobial stewardship really is. So this is about getting the best outcome for patients with an infection without causing them harm or as little as possible or increasing resistance. And we know loads of people receive antibiotics. 1 in 3 patients get one every year. It tends to be get more courses the older you get. 1 in 3 people in the hospital are taking an antibiotic at any one time. It drops down to 1 in 2 if you stay for more than a couple of days. And even though antibiotic usage has probably remained about steady since pre-COVID times, people don't realise that harm increases by about 3% per day when you're taking antibiotics. So we are harming patients with that exposure. And resistance increases by 4% per day on there. So one of the things around that we really try and focus on in Steward is actually try and get people to avoid getting infections in the first place. So by improving hand hygiene, food hygiene, but also the uptake of recommended vaccinations, annual influenza, pneumococcal vaccines, RSV vaccination. And all of these have been shown to significantly reduce antibiotic use. And then we've seen things through Pharmacy First come out more recently. And so interventions to use antibiotic alternatives. So local anaesthetic ear drops for acute otitis media, we see in children, or using things like really old drugs like methenamine instead of antibiotics for recurrent UTI prophylaxis. And then the final bit really around the stewardship is patients will need antibiotics, but actually when we use them, we should actually use the shortest course possible of the narrowest spectrum antibiotic, whether this is in the community or the hospital. And certainly we're pushing 5-day courses where NICE recommend 5 to 7 days. And this alone would actually reduce exposure by 29% per course. So it makes a real sort of difference. So that's really where we are with antimicrobial stewardship is we know that antibiotic resistance is like a continual sort of wave that keeps on coming. There are few antibiotics that are coming through in sort of the pipeline. So we really want to try and preserve what we've got already.
Absolutely. I mean, again, a lot of the educational materials that I've been involved with producing over the years have been trying to help clinicians determine who are these patients that we need to be concerned about, who are presenting with infections, where it's more likely to be a bacterial cause for their infection, and they're therefore more likely to benefit from an antibiotic. So a lot of the work that we did at NICE around the Common Infections Programme was very much around that. And actually just showing people the normal length of illness course is something that can be really, really helpful. If you can reassure people who turn up at your surgery or in your community pharmacy that actually having a chest infection or symptoms of a chest infection in an otherwise healthy, non-young, non-old person, you can have symptoms for about 3 weeks and there's nothing to worry about there. If it goes longer than that, then yes, maybe. But just that reassurance can really help, can't it, Phil? So yeah, we mustn't take our eye off the ball on antimicrobial stewardship. It's still really important, and I think the issues that you talked about are really helpful. So, in terms of penicillin delabeling, then, so first of all, what do we mean by that?
Yeah, so one of the things we need to remember is that true penicillin allergy is life-threatening and can cause anaphylaxis or severe cutaneous reactions, often within an hour of taking the antibiotic. And some of the research that we've done looking at some of the GP databases shows that between 6 and 8% of the UK population actually has a penicillin allergy label. And this equates to between 4 to 5 million people. So that's a huge amount have a penicillin allergy label. But research also shows that up to 95% of these labels are inaccurate when you do any testing for them. Now, NICE in 2014 brought out a drug allergy guideline, which was a really good piece of work. And it said that allergies should be assessed when they occur and recorded on the patient's record with the nature of the reaction and the date it first occurred. And this should be shared with all communication. The problem that we've had is as we move from analog, so paper notes, to digital, they were often transferred by sometimes receptionists in GP practices or elsewhere. And sometimes the only thing that got transferred over was just the name of the drug, rather than what the nature of the allergy was. And that causes a problem. So penicillin allergy labeling, or PADL, I'll refer it to during this, is really the assessment of the allergy label and correcting it if it's inaccurate. And this can be done by drug history alone, as we know that up to 10% of patients have actually had a penicillin since the label was put on their records. And or it might simply just be an intolerance. And most penicillin challenges nowadays are using either just a single or a two-dose strategy of oral amoxicillin, and then just observing the patient to see whether they have a reaction or not. Occasionally, we need specialist assessment for patients who are at really high risk of having a reaction, and they might use intradermal skin challenges that's still used.
The examples that I can think of are friends and family who take antibiotics, penicillins when they're a child, don't feel very well as a result of taking penicillin, maybe vomit, and are therefore labelled incorrectly as having an allergy to penicillin, when in fact that might just have been the normal course of their illness in the first place. And they carry this label with them forever without that ever really being, as you say, tested under sort of clinical conditions to see whether it is a true penicillin allergy or not. I mean, is that essentially what we're talking about here?
Yeah. So I'll tell you why it's a concern. It's a concern because, and we only have this from epidemiological studies, which are looking at associations for those with labels or not. Some of the work that we did has shown if you have a penicillin allergy label, whether it's real or otherwise, then there are an extra 6 extra deaths per 1,000 people within the next year, just by having that label. If you have pneumonia, there is an 8% higher mortality risk connected with it. You are 20% more likely to be hospitalized. You are 10% more likely to be admitted to ICU because you generally don't get the first line choice of antibiotics. And sometimes there are delays with people knowing which antibiotic to use in there. We also know there are big problems to do with resistance and healthcare acquired infections. You're 70% more likely to be colonized with MRSA. You are 26% more likely to get a Clostridia difficile infection if you have a label. You have over 80% higher risk of getting a surgical site infection. You have 5% longer stays in hospital. Prescribing costs are 28% higher, is what the literature tells us. And we know that these patients are more likely to get broader spectrum antibiotics. And these often have higher levels of resistance, or they cause more harm. We've seen the endless alerts coming out around the use of fluoroquinolones over the last few years related to some of these. So there are some real sort of challenges. And this is why we want to really focus on this area, because once you've got that label, it's with you for life. And it's actually a health inequality having that label, and you want more risk of getting all of the things I've just highlighted.
Yeah, I mean, for me, there's a massive incentive here for clinicians and indeed patients to make sure that their labeling of penicillin allergy is correct and not potentially inappropriate or false. I mean, some of those figures are really quite scary, Phil. They really are. I mean, if that was me, and I luckily I don't have and never have had any notion of allergy to penicillin, but if I did, I think I'd probably want that to be investigated to see whether it was a true allergy or not. So I guess there's an implication there for the workload on the NHS, then, isn't it? And I know that was some of the feedback we had from the NICE guideline on drug allergies was, well, how on earth is the service going to cope with all this and all this potentially allergy testing, etc. So I guess the question from me is, what should we be doing about this then? And what are you guys doing nationally about this?
Yeah, so thankfully we are doing something because it's such a big issue, and it's actually included in the UK AMR National Action Plan. And so Natalie Fleming is a project support officer working in my team, and she's actually leading a project about implementing the results of some of the NIHR PADL studies that have taken place. And she started that back in June. So the research I mentioned before is the Alabama, which is a program grant for penicillin allergy delabeling, of which had a number of work streams. But it actually showed through probably the only ever randomized controlled trial that a GP-initiated referral for penicillin allergy assessment by allergy specialists in hospitals is actually safe and acceptable for patients, and it ends up resulting in patients receiving more penicillins and less alternatives. But the most important piece of this work was other studies have shown that up to 50% of patients who are delabeled end up being relabeled. The tools that are developed within our program grant showed that at 1 year, 95% remained still delabeled, which was really impressive. So Natalie's leading a massive piece of work, pulling in experts from all around the UK, from allergists, those early implementers, those doing the research, about coming up with different models for developing these PADL services. The problem we've got at the moment is there is only one allergy specialist for 19,000 patients with a penicillin allergy label. And so we're never going to train enough allergy specialists in a short period of time to do these. We really need a risk-based approach so we can use other non-specialist staff to do this. And there have been plenty of tools used globally across the world to allow you to assess the risk of challenging somebody with a penicillin who's got a label on there. So we can easily split them into sort of low, moderate or high and put them down a particular sort of pathway. Now, Scotland and Wales have had for a long time some assessment processes for penicillin allergy labelling. Wales is relatively new, but in Scotland, they don't have any data to almost say how many patients they've delabeled and any increase in the use of penicillins compared to others. Within England, the British Society of Allergy Clinical Immunology have developed a guideline for non-specialist delabeling in hospitals of low-risk patients. And this was actually tested in an NIHR study called the SPACE study, which actually showed that 60% of the patients were classed as low risk of us having serious action if studied, but only 12% of those could actually be delabeled by either a nurse or a pharmacist using their guideline. And there are quite a few people who think it's too strict a guideline, and other centres have used different methodology and delabeled much higher ones. We're also developing some more SNOMED codes. So at the moment, there are SNOMED codes to actually list if you've got an allergy, but there aren't any for assessing the risk. And so that's one of the things we're working with NHS Digital and some other groups at the moment, and also to record the outcome of the tests where we're doing the assessments going forward. There are some other really big pieces of work going on at the moment. So there is currently a national allergy strategy for patients that's been developed, which is a 10-year strategy. And penicillin allergy will be very much centre of this. That's a big piece of work. This will come out this year, moving forward with this 10-year period. We're also seeing the next few months from NHS England some non-specialist allergy service commissioning guidance for ICBs coming out, so that will give us some more things. We're also asking NICE to update their 2015 drug allergy guideline because we think there's new evidence coming through. We'll have specific guidance for children. There will be education, training and assessment resources for non-specialists on there. We've also got search tools that exist, so where people have developed them on EMIS and System 1. So we've shared some of those already. We've got a prescribing incentive scheme for primary care, which is about to be uploaded. And we've shared any of the guidelines and protocols for non-specialists who are early adopters in hospitals. And all of these are hosted on Future NHS. So if people go to the AMR workspace, they will see penicillin allergy on their front and center, and you'll share the resources out there. So what we're trying to do is get everybody as we move along to be on this journey of trying to get rid of these inappropriate labels. As I said, we're probably doing this over a 2-year period, and we're probably 6 months into it at the moment, focusing really hard to make these really essential improvements for patients. Getting patients involved is really key. I've met various people on trains who've had penicillin allergy tattoos on their arm and had conversations with them, almost to try to say to them, this isn't a badge of honor. Having a penicillin allergy label is bad for your health, and we really need to change that mindset. For some patients, it's still very a big issue, scary. Occasionally, there are deaths related to it, but overall, we've got to see to change the mindset of patients to say, actually, having this label doesn't get you special antibiotics. It gets you second, third line antibiotics, and we want to make sure you get the best possible treatment for your infections.
Yeah, that's a really important point, Phil, isn't it? So, I mean, that all sounds great in terms of a plan, in terms of the strategy, a look ahead to producing some clear guidance, getting NICE perhaps to change their guidance, etc. The one thing I was going to ask was, what about members of the public? How do people outside of the NHS access this stuff? If it's hosted on Futures, I think you have to have an NHS email address to access that stuff. So is there a plan for this to be made more widely available outside of Futures? And in particular, what about the patient-centered information here as well? Because I think, as you say, if anyone who has a penicillin allergy, it's not, as you say, it's not a badge of honor. Actually, it needs to be investigated to make sure it's for real. Fair enough, if you've had an anaphylaxis and you required, intubation because of your penicillin being administered to you, absolutely fair enough. But not if it's been a mislabeling, I guess. So yeah, I'm just coming around. So in terms of the future, then, is the plans for this to be hosted outside of the NHS, sort of the Futures platform? And what about patient-facing stuff?
Yeah, so most definitely. One of the problems we've got at the moment is a bit of a chicken and egg. We've got 4 to 5 million patients with a penicillin allergy label at the moment. We've got a very small number of allergy specialists. We've got some systems that are being set up for non-specialists on there. And so one of the bits that we will end up sort of doing is, as we develop these models and we have some early adopters, we will start to make some progress on this. Don't want to openly advertise to patients until we've got something set up to allow us to deal with the potential backlog. And one of the bits that we are working on really carefully is being able to flag patients to know whether they're high or low risk based upon what's on the system, and then knowing what numbers are likely to go through different pathways. So the patients will be on a journey, and different ones will be invited as things go along. We've already co-produced a number of tools with patients and GPs as part of the Alabama work, which is around actually making it patients and GPs aware that is penicillin allergy delabeling through often oral challenge is safe, and it will allow us to use penicillin labels, and there aren't any signals coming through from randomized control about this. So we already have these tools out there which have been co-produced. These are available on the website that we will share. When the National Allergy Strategy, which is the patient focus work, is actually launched, big element of that will be for the patients on how we make it aware. There are, however, some areas whereby, for instance, if you go down to Middlesbrough, for example, they've set up off their own back penicillin allergy delabeling clinic in a hospital that's led by a pharmacist and pharmacy technician. And they can take referrals from inpatients, direct referrals from GPs, but patients can also refer themselves in. And so they run a clinic sort of on there. And so there are early adopters who set up some of the examples like that. So we will have these bits available for everybody. but we want to do it in the right way, working with the National Allergy Strategy to make sure we have sort of uniformity what's happened and we don't drive some of the inequalities in that healthcare delivery.
Yeah, I mean that makes perfect sense to me. And clinicians and the service would not thank you if you launched this big style, you know, headlines in the tabloids and in the broadsheets and on the BBC and other news outlets saying, "Go and get your penicillin allergy investigated," when the service is not ready for that. So I completely get the need for it to be careful and have a proper comms communication strategy lined up for that. So that all makes lots of sense. So just in terms of where we are now, then, and just to finish off, really, what would you say would be the three things you'd say to clinicians for what they should do differently as a result of this at the moment?
Yeah, so you imagine I've got a big long shopping list, what I'd like people to do. But if my desert island,
Three.
three, the three go like this. So first of all is really getting people to update the primary care allergy record in line with the NICE drug allergy guidance. So that's the first thing. It should happen, should be in place anyway, but we know when things transferred over from paper to digital, perhaps the detail wasn't included. So this needs the drug, so whatever the antibiotic people are supposedly allergic to, the nature of the reaction and the date it occurred. And any new allergies being put on the system should follow the same standards. Now, this can actually be done part of the PCN directly enhanced service as part of the structured medication review, or as part of the duties listed for pharmacy technicians for antibiotics within the DES. So there's a structure there for it to happen already. But there's also the part which is around any patients who go in to hospital either for an acute admission or pre-admission for surgery or chemotherapy and have a meds reconciliation done. That's another real opportunity to do it. And then to make sure that's communicated to the GP and the records are updated. So that's my first thing. Let's get the house in order, first of all. Back to the original NICE drug allergy guidance, which made it really clear what happened. The second bit is I'd like to see people go and use some of the existing search tools. Ardens are in the process of developing one for EMIS and System 1. But we also have some in our toolbox, which we've got on Future NHS. We already have some which are being developed independently by others already. And we know if you run these searches, you'll probably find about 10% of your patients who've received a penicillin since the label went on. And some of the work that's been done locally around here has actually shown that if you speak to some of those patients, about 80% of those can actually be delabeled. So you have that conversation with the patient that takes place. So that's my second one. And then my third one is, and I know things are difficult at the moment within ICBs, but actually establishing or commissioning a non-specialist PADL clinic or service for low-risk patients in conjunction with your local hospital would make a real difference. And I mentioned the one in Middlesbrough early on there. And a lot of these have done it without additional funding. They've just said, this is the right thing to do because of an antimicrobial stewardship intervention. It's got better outcomes for patients without causing them harm. And we've been doing some work with NITCAR. So NITCAR are the National Infection Trainees. They do an audit each year. And they've actually surveyed all hospitals in the UK. And 17% of hospitals are already using oral penicillin allergy challenges already. So it's not like this is something totally new. We know that almost a fifth of hospitals already got something in place at the moment, and certainly we're sharing some of those resources. So in my top three, there's a bit for everywhere. Bit for primary care, for updating the current allergy records. There's something about looking for patients who've already received penicillins despite having a label on there since it's gone on. And then really starting to have that embryonic working together between primary care and hospitals for the low-risk patients to see if we can set up some of these assessment processes for delabeling moving sort of forward. And because I mentioned earlier the impacts it will have on reducing hospital admissions, because we know there's so much pressure, this fits in with our hospital into community within the in the 10-year plan moving forward. All of this makes a real sort of difference coming in, and we'll have loads of other tools in there, but they're the simple bits, I think, that can make a bit of a difference.
Yeah, I really like that, Phil. And they're all achievable now. People can do something about that now.
Yes, and we've got lots of tools.
Absolutely. I think the other thing, it would be remiss of me not to mention the kind of, when you're doing your searches, have a look for penicillamine allergy as well, because there was a national patient safety alert, wasn't there, about people being mistakenly labelled as having penicillamine allergy when they've actually got penicillin allergy. So be interesting for people to have a look and see how many people you have in your lists with penicillamine allergy. So brilliant, Phil. That's been so helpful. There's obviously lots and lots of work going on in this area. It's such an incredibly important area, and one actually that we can do something about with a bit of effort. It's going to take effort, and it takes a coordination. I completely get the need for the ducks to be lined up before we go large on any of this stuff. But it's such an important work stream. So thank you to you. Thank you to Natalie and the others within the work stream as well. So and we'll look forward to seeing the fruits of this being available to us all to help us do something about inadvertent penicillin labelling. So thanks, Phil, and we'll see you all soon. Bye.
Bye-bye.
We hope you enjoyed today's podcast, and we'll see you in a couple of weeks for the next episode of Talking Meds from PrescQIPP, engaging conversations about medicines-related dilemmas. Please follow us on LinkedIn and Blue Sky to join in with the discussions, and email us on talkingmeds@prescript.info with your feedback or suggestions for future topics or guests. Please don't forget to register for access to the PrescQIPP website for all of our excellent resources.